morning and good afternoon to everyone, no matter where you may be, throughout Australia, New Zealand, and also parts of Asia. My name is Gary Morrison, and I'm part of the management team of the Shine a Light Cancer Support Group here in Sydney, Australia. I'd like to welcome you to the second in our webinar series. Before we do go any further, I'd like to do a brief welcome to country. In recognising Aboriginal and Torres Strait Islander people's spiritual and cultural connection to country, and in the continuing commitment to reconciliation, I would like to commence today's webinar by acknowledging the First Peoples and the traditional owners and custodians of the country where we are. We respectfully acknowledge our elders past and present, and remember that they have passed on their wisdom to us in various ways. Let us hold this in trust as we work and serve our communities. Thank you very much. Today's webinar topic is erectile dysfunction. Being a cancer survivor, I know that when I was initially told that I had prostate cancer and was choosing the pathway for treatment, that erections and also incontinence were the two key things that I was concerned about. Now being a support group leader some 13 years later, that hasn't changed. Any new members to our group, if they're beginning their cancer journey, are always concerned about what the side effects might be after surgery. This topic today is a topic which we know there has been an immense amount of interest in, and it's being recorded. So for those support group leaders that want to use this particular webinar in their support group meetings later down the track, we encourage you to do so and welcome you to do so. My co-chair today is Dr. Kalli Spencer. Kalli is a urologist and will be chairing the majority of today. I'd like to welcome our two keynote speakers in Professor Dean Knoll and Professor Phillipstricker, Dean in Tennessee in the United States and Philip here in Sydney, Australia. Welcome to you both. I know Kalli's going to do a more formal introduction. We encourage you during this webinar to use the question section as much and as often as you wish. And we will, in this 2-hour session, be able to cover and answer most of your questions without doubt. In our previous webinars we've held, one of the key feedbacks that we've had has been that everybody was delighted with the fact that their questions were addressed. So enjoy the webinar. I'll speak to you at the end of it, and thank you all for attending. Kalli.
Thank you, Gary, for the welcome. And I'd just like to welcome our two guests and thank Dean for joining us at 10 o'clock on a Friday night. I mean, that really is dedication and devotion, if you ask me. So thank you. And of course to Professor Phillipstricker, who's joining us on his Saturday. So we appreciate that too. So we have, placed the biographies of our speakers there in the initial registration, but just to remind you, we're very privileged to have really internationally renowned speakers here with us today in the field of both prostate cancer, but of course also sexual medicine and sexual dysfunction. So I'll start off with Professor Phillipstricker, who's based in Sydney, Australia. He works at the St. Vincent Private Hospital. I put down over 20 years of experience, but in our pre-meeting discussion, it seems like it's closer to 30 years of experience in treating prostate cancer, and really has been a pioneer in the field, not only locally, but internationally as well, and probably has one of the largest collection of prostatectomies in the country. He's also the clinical director of Australian Prostate Cancer Research Centre at the Garvan Institute in Sydney. So welcome and thank you for joining us. And then we also have Professor Dean Knoll, who is a urologist based in Tennessee, United States of America, with a particular interest in surgery for erectile dysfunction, and he's a frequent contributor to the medical press, having published over 100 peer-reviewed articles, abstracts, book chapters, and he's a principal investigator in over 110 basic science and clinical trials of new devices as well as pharmacotherapies. Now, the story of how two speakers actually know each other is quite interesting. I'm just wondering if perhaps maybe I'll hand it over to Philip to explain how you two actually know each other. So I'm going to hand over to you.
Thanks, Kalli, and thanks for the privilege of being able to speak, one with an ex-patient, one with my dear friend, and one with you, Kalli, who I understand is a urologist as well. And I don't know, I always want to make absolutely sure that everybody feels comfortable with asking questions as we go. 1992, I'd already subspecialized in prostate cancer and sexual dysfunction, and I started a thing called the Australian Centre for Sexual Health, which was the largest sexual dysfunction clinic in the Southern Hemisphere. We had about 20 people working in it, and many famous names have come out of it. Rosie King, now legendary, Chris McMahon, Michael Lowy, the main two people. But I had a conference at that time, getting the best surgical minds in the world to come and have a conference. And the two main people in the world were Bill Furlow and Tom Liu. And this little young sidekick came along called Dean Knoll, who was the registrar. But Furlow said he operates a bit better than me, so I'll let him do the operating during the conference. And we started a 30-year friendship from that time, where we've maintained close contact. I've shared my challenges with him, and he doesn't have any challenges because in Tennessee there are no challenges. But we've always maintained a really close relationship. So it's an absolute pleasure on many different levels to be doing this talk today, and I'm looking forward to it.
That's great. Thank you. And what an interesting story, and so great that you're still friends after so many years. So yeah, just a reminder, as Gary said, please, for those that have just joined us, you can use the Q&A at the bottom of the screen to post your questions as the talk's going on. And then I think we'll wait till the end, and I will pose those questions directly to Professor Stricker, who can answer them. And then Professor Dean Knoll will do his presentation. We'll answer any questions from that talk. And then we will have a bit of a panel type discussion at the end if there's any other questions after that. So yeah, I think over to you, Prof, and you can begin.
So I'll share my screen. Just go back a bit. I'll just double check that you can see my screen.
Yes, we can.
Okay, I'm just going to minimize you guys. There we go. So I was asked to give the first half of this talk, which is on sexual issues, and it wasn't related necessarily to just prostate cancer, but sexual issues in general. And I've left the second part of the talk more on the surgical side of sexual issues. So I'm going to skate through some background and obviously happy to address questions on any level of this. So sexual dysfunction means interest, ability to get an erection, and then ejaculation, orgasm. And they're all aspects of sexual function. And they're all different in terms of management. The normal sexual response is you get sexually interested, you get penile tumescence, you get aroused, then there's often penetration, and then there's orgasm, and that's associated then with ejaculation, biorgasm, and penile detumescence. And that's the normal pattern that occurs, and things can go wrong at any point. Obviously, we're only talking about male sexual dysfunction in this particular topic. So I did take out the female sexual dysfunction, which is much more, less studied, I suppose. So erectile dysfunction means the penis can't get hard. So erectile dysfunction can mask as yet undiagnosed other health issues like diabetes or cardiovascular disease. And but even if it does come from a vascular problem, there are almost always psychological issues, because men are fragile beings and you get a performance anxiety as a result of not being able to function normally. And when we go to books about sexual dysfunction, we say some cases are due to psychological issues, some cases are due to vascular issues, some cases are due to hormone or endocrine issues, such as low testosterone and other causes like diabetes or low thyroids. Of course, spinal injuries can cause sexual issues. Problems with the actual penis themselves, like scar tissue in it called peyronie's, which I suspect Dean will talk about as well, or radiotherapy or damage to the end organ. And then finally, some of the tablets that we give out, antidepressants, various beta blockers, can also cause erection problems. One of the important things to realize is that when you develop an erection problem, particularly if it's unrelated to any prostate cancer issues, sometimes that can be the first sign that you've got a problem with blood vessels, and it may be a marker of silent vascular disease. For example, it precedes coronary artery disease by about 3 years, and it may indicate the presence of low testosterone or insulin resistance. With regard to medications, there are some medications which are unlikely to affect sexual function, but there are some medications which are likely to affect sexual function. The ones that are likely to affect sexual function are what's called beta blockers, statins or diuretics, or antidepressants or antipsychotic or recreational drugs. So with the recreational drugs, you might feel better, but it might cause erection problems. And that extends to alcohol as well. This is a really complex slide, but it became really super important when the first drug, Viagra, came on the scene. They worked out, and I don't know if you can see my arrow, but they worked out that the nerve endings that go to the smooth muscle of the penis work through a thing called nitric oxide, which then stimulates some chemicals inside the penile smooth muscle. And by manipulating these chemicals with a group of drugs called PDE5 inhibitors, you can make erections work much better. And that was the basis of Viagra or sildenafil. And since then, there's been a bunch of other tablets in the same group of drugs. And it was really a blockbuster. I think Pfizer even made more money with Viagra than they did with the vaccines. Now, the artery to the penis is about 1 or 2 millimeters in size, and the artery to the coronaries is about 3 to 4 millimeters in size. So they're not that dissimilar. So when a person develops impotence, and it might be due to vascular causes, you always need to double check your heart as well, because obviously it could be psychological, which will have no effect on your heart, but I think it's just a warning sign. Now, the way things work is you get a sexual impulse, the brain sends out a message with nerves to the penis, and that nerve then releases a chemical called nitric oxide. The smooth muscle of the penis relaxes. It allows blood to come in. That blood fills up the penis and compresses the side and the hard bit of the penis called the tunica. And then the penis becomes hard, and then you get an erection. So that's the process of getting an erection. And obviously, if anything happens in that process, then you can get a problem with erections. For example, with prostate cancer surgery, just by an example, if the nerves which are injured or temporarily bruised, then the nerves can't send the sexual impulse to the penis. Diabetes is another cause of erection problems for 2 reasons. 1, because it affects blood vessels, but 2, because it can affect nerves. And And then, of course, it's even more complex because then, of course, there's emotional distress, and also it can sometimes cause hypertension and low testosterone. So diabetes can attack erections on multiple different fronts. Generally, when we're getting a history from a person, we get their general history, their psychological history, their medication history, use of substance, and obviously the relationship and stress and everything else in the family. We as urologists who deal with this, or sexual health physicians, try to largely group people into a physical problem or a psychological one. A physical problem, where there's a problem with nerves or blood vessels, tends to be of gradual onset in an older man. It's there all the time. It affects your morning erections as well. The erections won't work with masturbation either. But orgasm and ejaculation still remain okay. And you've obviously got risk factors, maybe diabetes, maybe vascular disease. Psychological, on the other hand, tends to have a different pattern. It occurs suddenly. Maybe somebody said, you've got a small one or something. And then suddenly, that moment on, you get a sudden erection problem. It's in a younger man. It's variable. Sometimes you got erections, sometimes you don't. It's situational, where you're anxious. But the morning erections are okay and the masturbatory erections are okay. And orgasm and ejaculation varies, and the person's generally in good health. So you can, on history, separate the two broad categories. Now, the age difference of sexual function, the younger man, psychological things cause more of the problems. Anxiety, despite a high libido, occurs, and there's often intimacy and relationship issues and rapid ejaculation. With the older man, it's different. It's usually a physical cause, libido slowed down a bit, you've got erectile dysfunction, and ejaculation's delayed, not rapid. So there's a thing called aging. Unfortunately, there is not much way of stopping it. And what happens in a normal male as they age is it takes longer to achieve erections, more difficult to sustain erections. You need more tactile stimulation. The orgasm's less intense. You have reduced volume of ejaculation. Takes longer between a full erection to the next time you can get an erection. Medical conditions affect it. And if you don't use it, you lose it. There are lots of different ways of assessing the penis, but generally history alone is what happens. But there are special ways of measuring the blood flow in the penis, and these are penile Dopplers, and in very specialized units. And we used to do this at the Australian Centre for Sexual Health. We might look at these type of things and even very rarely even repair blood vessels to the penis. I'd like to move away from the general erection problems to a specific problem now called Peyronie's disease or penile fibrosis. There's a condition which occurs in about 3% of normal middle-aged men, where scar tissue occurs in the penis, often causing a pain on erection, a bit of a lump and curvature, shortening of the penis, and then subsequent psychological issues. Sometimes that just comes out of the blue, but sometimes it comes as a result of the use of penile injections, and very rarely it occurs as a result of a very prolonged erection for some reason. Here, I haven't got a wrong slide. This bending of the hand here, of the fingers, called trigger finger or Dupuytren's contracture, is the same condition that causes this bending of the penis here, called Peyronie's disease. And they call it the Viking disorder because it seems to have originated in the Vikings, and it's due to a genetic disorder that causes this. And so Peyronie's disease, which is a very bothersome condition of men, is often associated with this hand trigger thing. So it doesn't mean that you're going to get Peyronie's disease, but if you've got the trigger finger, but if they're associated. And what it causes is the scar tissue, which causes bending and shortening of the penis. And as you can see, it also causes a bit of an indentation of the penis. And I'm sure Dean Knoll will address that. Now, testosterone causes loss of nocturnal erections. And so if we now start to talk a little bit about the hormone side of normal sexual function, just to show you what happens during a normal man's sleep, he gets about 4 erections, maybe 5 each night, and usually during what's called rapid eye movement sleep. And that's normal. And whether that's makes the penis more healthy, it probably does. And there are even machines that can monitor these erections at night to help work out whether it's whether the erectile function is normal, in which case the overall sexual problem is psychological. But this is more to explain that when you have low testosterone, for example, these normal nocturnal erections become less common. There's another cause for erection problems is sleep apnea. And it's interesting how common this is in Western society. Sleep apnea causes 2 really interesting things. One's erection problems, but 2, it can cause getting up at night time to pee. Sleep apnea is a treatable condition and is one of the things that you look for when people develop erection problems as they get older. One of the other things we have to also address when we're looking at sexuality is how the world looks upon sexuality in older men and women. We did a really interesting study in 1992 where we put a very old man and woman kissing each other in Centennial Park, and then we had 18-year-old guy and girl kissing each other in Centennial Park, and we asked people what did they feel about that, and they were delighted with the young people and really disgusted with the old ones. And so it's actually quite interesting about the negative community attitude we have on older people. I think that's better than it was, but I think it's another thing to take it into consideration. And then, of course, there's the interaction between the doctor and the patient. You know, some doctors are embarrassed to bring up these things. You know, he says, as in the cartoon here, if there's a problem, I hope the patient brings it up. And of course, the patient doesn't talk either. I hope he asks me. In terms of treatment, the very first treatment for erection problems was not Viagra. It was actually injections with a thing called prostaglandin E1. And at the time, the company that made it was called Upjohn, which was just by coincidence. And Cavaject now, which is a very valid treatment for an injection into the penis to cause erections when erections don't occur, for either physical or psychological problems, has come a long way. But generally, the medications are the first line of therapy. And with injections like these, in modern day injections, very often we get compounding pharmacies to mix up a bunch of tablets to treat erection problems with the minimum side effect. And the sexual health physician usually supervises that. It goes into the penis. Yes, it feels, you know, it looks worse than it is. And there is often a bit of a phobia about doing this type of thing. But once a person's mastered it, it works very well. And it can, unfortunately, given too much, cause prolonged erections or priapism. And that's a problem because you then need to either take a tablet to get it down or you have an injection to get it down. But usually if it's done carefully, this is rare. In terms of the tablets, the first one, of course, was Viagra, and it comes under different strength. The second one was Tadalafil or Cialis, then came Levitra, and most recently Spedra. It's important that medications called nitrates, which normally are used for people with heart conditions, are never used with these tablets. And it's really critical that you don't, because in the very beginning, in the early 90s, there are a couple of bad outcomes because of the combination of these two. I think it's also important to avoid sexual intercourse if your heart is so tenuous that it can't even walk up a set of stairs. But I think that's a different issue. And I think there was a very good movie with Jack Nicholson in it, which I can't remember the name of the movie, but it illustrated it. If you're comparing the 4 tablets, then they have different times that they last. For example, Cialis or tadalafil lasts the longest, but it takes a bit longer in your system before it works. For example, with Viagra or sildenafil, you have to take it about an hour before, but with Cialis, you have to take it at least 2 hours before. The side effects of these medications is a flushed face, headache, nasal congestion, gastric reflux, and muscle pain, particularly with Cialis. But again, used correctly, I would say that this is bothersome in less than 10% of people. At least the first time, you should avoid alcohol. You need to take it at least an hour or maybe 2 hours before. Stimulation is required. These tablets do not cause erections, and lack of spontaneity is an issue in some cases, which leads some people to actually take them on a daily basis just in case. Another option for treatment of erection problems is using a vacuum device. Again, a little bit more premeditated, but there's no needles. And if the tablets don't work, it's a really reasonable option. There are ejaculatory disorders, not just erection problems. The commonest one would be premature ejaculation, but delayed ejaculation can also occur for psychological reasons. And the cause of premature ejaculation can be many factors, but generally is more a psychological issue. Now, if you look at the normal response of erections and then ejaculation, that's the normal response. But with premature ejaculation, everything happens extremely quickly. Now, can erection problems cause premature ejaculation? It's hard to know for sure, but they're often mixed up together because the person's so scared his erection's going to go that he gets premature ejaculation. The treatment of premature ejaculation is various behavior things. Stop in the middle of sexual function, squeeze the base, take tablets that might help, use the injections, use sprays that decrease the sensitivity of the penis, pelvic floor exercise. And there was even some people in Brazil that were dividing nerves. Retrograde ejaculation, which means a dry ejaculate, which goes backwards, is common after prostate surgery or some type of medications or some medical conditions. This is quite different. And just the last section of the talk, I was going to talk about testosterone. And if testosterone becomes low, then that can have effects on sexuality as well. Just to give you a number, at age 65, 10% of men have androgen deficiency, and this increases to 20% by the age of 70. And this is the normal testosterone decrease. We call it andropause rather than menopause, as testosterone slowly decreases with age. Low testosterone can decrease libido, even decrease erections and retard ejaculation. It can have physical effects, and by causing increased fat, decreased body mass, but you can't blame low testosterone on every piece of obesity that you've got. Now, psychologically, you can even get a loss of memory, you can get more irritable, you can become depressed. And so if you really do have low testosterone, that's something that's worth investigating. Now, if your normal testosterone greater than 12, then you can't attribute those symptoms to low testosterone. If you've got a very low testosterone, less than 6, then you can attribute it. And in the grey area, it's controversial. When you do these testosterone tests, you have to do an early morning testosterone, and really an endocrinologist should be involved in the care, looking for the possible causes for that and getting a better understanding of the testosterone. And this is a specialist field. There are a whole ton of different non-invasive ways of treating low testosterone. And again, this should ideally be under the supervision of an endocrinologist. Now, the positive effects of testosterone treatment is that it improves lean muscle mass, decreases fat, improves bone density, improves sexual function. But there's a downside to having testosterone, particularly if you don't need it. It can increase your red cell count. It can raise your blood pressure, can cause edema, and even cause sleep apnea and prostate issues. There are many good handouts from the Prostate Cancer Foundation and Andrology Australia, which can help you read about all these issues. But I think at this stage, I might cut my talk off so that I can ensure that questions can be answered, and also Dean Knoll can do the surgical side of things. So thank you for your attention, and I'll open up I'll let Dr. Kalli decide how he wants to run it at this point.
Thank you so much for an outstanding talk. I think your talk was so thorough and comprehensive, we've had no questions. You've answered everything in your talk. But I'll ask you something, because a lot of our patients that join the sport group are on androgen deprivation therapy as a treatment for their advanced bladder cancer, and obviously therefore have the sexual dysfunction. I mean, what are some of the current theories around giving testosterone replacement to patients that already have prostate cancer?
So I think there's different categories. If you've got a low-risk prostate cancer and you're only on active surveillance, then bringing a low testosterone to physiological normal levels is quite okay. I think the enormous fear that testosterone stimulates cancer is not quite as it was in normal people. But on the other category, a really nasty cancer which needs hormone therapy or hormone therapy and radiotherapy, in that situation where you're using androgen deprivation therapy, there is no role for giving testosterone. And the only other thing that has come up recently is that there are some people with very rare genetic abnormalities called BRCA gene or mismatch repair genes. And if you have that, we've been doing some studies on a thing called bipolar, which is where you take away the testosterone and then pulse the testosterone. And in people with BRCA abnormalities, we've had remarkably good responses to prostate cancer in that group of people. But that's a very small group of people.
And would testosterone replacement be the only option in these patients? Would anything else work for them?
I think a lot of people go out and buy things from the chemist like DHEA, which is like a testosterone sidekick. But I think in these situations, if you genuinely have low testosterone and you genuinely have symptoms, I think you're better to have one of the more conventional treatments under the supervision of an endocrinologist.
Yeah. So a question came in, I mean, will the Cavajects, the alprostadol injections, will that work in patients on ADT?
Yes. So ADT, the main effect of ADT is it decreases libido or interest. It doesn't actually affect erections quite as much, because you may know in ancient Egyptian times, the eunuchs used to service the queen. And so they obviously had no testicles, but they were able to get erections. So erections and libido are quite different. And so in the situation where there's no libido, but the person wants to still be sexually active, then there's no question that the Cavaject will work.
That's great. Thank you. That seems to be all for the questions for now, but we can talk again when we do the panel discussion at the end of Dean's talk. So we'll leave it at that, and thank you again. Dean, are you happy to proceed?
Yes, Ready to proceed. Yeah.
Thanks, Nicholas. If you can share the slides for us of Dean. Okay, Dean, you can see your slides there in the window.
Yes, I can see him on the right hand side of the
So
screen.
you'll just say next whenever you're ready to move to the next one.
That'd be perfect. Philip, I want to congratulate you. That was an excellent presentation on how erectile dysfunction can occur, and certainly how testosterone comes into play with it, because those are always the questions that we get addressed as clinicians. Is my erection not working because my testosterone's low? And yeah, that's a very good discussion, and a very good discussion on the non-surgical aspects of dealing with erectile dysfunction. As we know, erectile dysfunction is actually very common. As Philip had mentioned, Dr. Stricker mentioned, there's many causes. There's vascular disease, there's diabetes, spinal surgery, and certainly and with regards to dealing with prostate cancer, despite the fact that the robotic prostatectomy is done to spare nerves, many times this isn't always quite effective. Next slide, please. So when we deal with the people that have problems with erectile dysfunction, it's actually very, very important. And Philip brought this up earlier, but it's very important for what are the best practices in patient communication. Obviously, erectile dysfunction is a very significant problem. And Peyronie's disease, as Philip had discussed, is actually even more distressful according to what the patient experiences with regards to the psychological repercussions than what happens with the patients who eventually gradually will develop erectile dysfunction over time. Obviously, it's important to make certain that we have great communication with our patients. These patients actually need more time, just as the prostate cancer patient needs a lot of time, or any cancer patient needs time to understand what their condition is and what can be done for them, and what's the most effective way of treating them, and to also psychologically make sure that we have these patients very comfortable of what's occurring. We as physicians need to make certain we listen to our patients, we understand what their concerns are. As I say, any patient who develops erectile dysfunction or Peyronie's disease are very, very bothered by this psychologically. So we need to take time. We need to take time as physicians. We need to take time as we have staff that helps us. I have many people who will talk to these patients as well afterwards and support them with whatever needs they may have. But erectile dysfunction and Peyronie's disease has a great bother factor. Next slide, please. When we see our patients, it's very important, as Philip had mentioned, that we make certain that we truly understand what the cause is. We want to make certain we understand that the patient doesn't have unrealistic expectations on what type of therapy we can administer. And so certainly it's important for us to make sure that we assess these patients. We can use, there's a term up there, physician assistant, or APP, we call it in the US. These are nurse practitioners that have been certified and trained in dealing with people who are having erectile dysfunction for whatever reason. Next slide, please. So as we deal with these patients, and Philip addressed this, we perform a good history, a good physical exam. We do this testing. He showed Doppler studies may be necessary in certain patients. And then we need to set expectations. And these are patients that a one-time consult many times is not always in their best interest. So I make certain that patients, when they're started on any type of therapy, particularly if it's oral therapy or injection therapy or vacuum therapy, that we get these patients back into the clinic, and we assess them. We ask them, are you comfortable with where you are? And that is important because many times, if any of the non-surgical therapies are not effective, well, then it's important to then address the next issue, which would be surgical therapy, and we'll talk about that subsequently. Next slide, please. Again, our responsibility is to make certain that the patients feel comfortable about their condition. Again, they're very, very hesitant many times to open up to talk about it, but it's important that we get the patient and hopefully their partners involved in the discussion, and it many times makes the planning and the implementation of surgical therapy very, very important. And it's our responsibility to make certain that the patients feel comfortable if they do decide to go on to surgical therapy when all other non-surgical therapies, which Dr. Stricker talked about, have not been effective. Next slide. So the treatment options already have been discussed. We know the causes. It can be psychogenic, neurogenic, hormonal, and that's already been discussed very well. But certainly when patients don't respond to oral therapy or injection therapy, or they're not comfortable with vacuum erectile devices that can create an erection, then the implantation of a penile prosthesis is a very effective therapy that's been around for over 50 years. Next slide, please. This here just reiterates again the time period that we really need to spend with our patients. It is very important. We need to explain to our patients what they can expect from the surgical therapy. So when I talk about patients that don't get good quality erections, we're talking about the implantation of a penile prosthesis. Penile implants, again, as I mentioned, there are various types, and we'll talk about these subsequently, have been around for over 50 years, and they actually work very well. If you look at many of the studies and the literature published in the urologic literature, the implantation of a penile prosthesis has the greatest patient and partner satisfaction of all the therapies that are offered for erectile dysfunction. Patients feel comfortable because they know they can get an erection when they want it. They can get an erection as long as they need it, and they can have normal sensation, normal orgasm, and normal ejaculation. And when they do not want an erection, they don't have one. One of the other most important things to recognize is that the concealability of the inflatable devices that we'll talk about, certainly it's very, very good. They can go to the gym, they could be in the shower, and nobody know that they would have a penile implant. And that's very important. And physically, what a patient does before they have an implant, they do their physical activity after they've had a penile implant. Next slide, please. Again, afterwards, it's important for us to make sure that the patients have the ability to understand what the function of a penile implant will be. That, again, it's most important for them to understand. And many, many patients, are so fearful of not having normal sensation, normal ejaculation. And so it's our job to make certain that we make sure they're very comfortable and understand what a penile implant does. So what a penile implant does is gives the patient rigidity, but it doesn't interfere with any other sexual function. So the rest of the sexual act is entirely up to the patient because they have the ability to have an erection when they need it, as long as they want it, and when they don't need an erection, they don't have one with the inflatable devices. Next slide, please. Next one. This talks about the surgery. Of course, we want to make sure we know their history. We want to make sure that we do everything we can to decrease the risk of infection, which is what's the major complication that can occur with the implantation of a penile prosthesis. And fortunately, over the years, and I've been implanting penile prosthesis for over 35 years now, and that is something that we're very fortunate to have occur less than 1% of the time. Next slide, please. And again, there's tons of information that's available for patients now. Certainly, as I've been involved with the treatment of ED with penile prostheses, the amount of education that these patients have the opportunity to see and learn about is outstanding. Nowadays, when I see patients who come in and I say, all right, well, this is how this works and this is how that's going to happen. And they go, oh, no problem. I've already seen that. I've watched it on YouTube and I've seen the surgical procedures before. And so this opportunity for patients to be educated well before they understand the treatment option that's about to occur is incredibly helpful. So the better educated that the patient is, obviously, the easier our job is to making sure that they don't have unrealistic expectations. And the fact of the matter is all of the social media, etc., all the information available makes this occur in a much easier manner. Next slide, please. Let's talk about the devices. Next slide, please. There's some potential complications that occur with penile implants. And as I mentioned, over the years that I've been involved with them, and I've been involved with design changes of some of the implants, when there was a problem, we'd go to the engineers and we'd say, this is a mechanical problem, we need to eliminate that. That's been very, very effective in making our patient satisfaction become a whole lot better than it used to be in the early days. We used to have a lot of mechanical failures, and that's now eliminated. Actually, the manufacturers in our country, in the US, give lifetime warranties to their devices. And in the inflatable device, which is a hydraulic mechanical system, that's pretty remarkable to be able to say that we think this is going to last many, many years. And I've had patients that I've implanted, I still see over 20 years ago, and the devices still work. But again, it's our duty to explain to them that the downside of the implants, there's still two potential complications. And I always summarize it this way when I look at a patient and I say, here's the positives. You take it with you wherever you go. You got an erection when you want it. You got an erection as long as you want it. Your sexual function, sensation, orgasm, ejaculation is intact, and your sexual partner's sexual function is intact. And when you don't want an erection, you don't have one. The downside, there's a less than 1% chance of infection. 25 years ago, that was 10%. Now it's less than 1%. And I won't go into the technicalities of how we've done that, surgical technique, antibiotic coatings on devices, etc. And the mechanical reliability. And that's why, as I mentioned, of all the treatment options for patients who have end-stage erectile dysfunction, the implantation of a penile prosthesis has the highest patient and partner satisfaction. Next slide, please. So there's the types of devices that can be available to patients. There's three types of devices. Two are inflatable, and we'll talk about that. And then there's the malleable penile prosthesis. In our country, there's two manufacturers. There's two devices where we have what we call as a malleable penile prosthesis. This is a rigid type of rod, but it has flexibility and it can be bent for concealability. The patient has an erection all the time, if you will, because it's always rigid, but they have the ability to bend it such that they don't have the erection sticking straight out. So that's a malleable prosthesis. And then there's many malleable prostheses across the world. And then we have two inflatable type implants. The middle slide shows a device that has a pump and two inflatable cylinders. And then, of course, the most common device implanted in, particularly in the United States, is what we call a three-piece inflatable penile prosthesis. It consists of a reservoir and a pump, and then two inflatable cylinders that go into the two erection bodies themselves. Next slide, please. This is, again, an example of one of the malleable devices. We measure them to fit, and they actually give very good rigidity. And these devices, again, are malleable so that when the patient doesn't want an erection, he's able to conceal it by bending his penis downward or upward, whatever direction they wish to have it positioned such that they don't have an erection sticking straight out. It's easier for the patient as far as use because all they have to do is position the implant so that they have the ability to have penetration and or non-penetration, but a rigid, straight penis. Next slide, please. This is the two-piece device. It consists of two inflatable cylinders, which we have two erection bodies. And then there's a pump reservoir placed inside the scrotum. So when the patient wants an erection, next slide, please. So when they want an erection, they're going to squeeze the pump mechanism at the bottom, identified here. So the fluid will transfer from reservoir of fluid in the end or the proximal part, or the part that's inside the most proximal part of the penis, and it transfers fluid into the cylinders, and the cylinders become very rigid. They have sexual activity. They'll bend the implant in the mid shaft, and then the fluid will go back into the reservoir. It's not that commonly used, but we use this in patients that we're not able to place a three-piece device which has a reservoir, and we'll talk about that in the next subsequent slide. Next slide, please. And this is just showing pumping it up, and then you would bend the penis, as you can see on the far right-hand slide, on how to deflate the device. Next slide, please. And this shows great patient satisfaction, which has been published in our urologic literature for many, many years and by many, many authors. And it, again, allows patients that want an inflatable type device, but cannot, they're not good candidates to have the reservoir placement, and they can utilize this device. Next slide, please. This is the device that's most commonly implanted in our country. And I've been to Australia many times, and I've seen it implanted by your excellent surgeons there many times. And this is the three-piece inflatable device. It consists of a reservoir, which is hidden underneath the abdominal muscle. There's a pump that's placed inside the scrotum next to the testicle. And then there's two inflatable cylinders placed into the two erection bodies. And again, these devices now are either hydrophilic coated, or obviously they're coated with antibiotics by a substance called inhibizone, which contains two antibiotics coating the device which over a 2-week time period releases directly into the tissue. And this subsequently is revolutionized the prosthetic surgery of penile implants by decreasing infection rates from close to double digits now to less than 1 person per 100, which is excellent. Next slide, please. There are various sizes to these devices. Patients always ask me, make this device as long as you can. And we do utilize a surgical technique and a device that stretches the penis to its maximum capability of being stretched. And then we implant the size that they can accept. What people always need to understand, and this is a very important thing, and I spend a lot of time talking to my patients about this, is number one, when patients lose their ability to get a good erection, the smooth muscle inside the penis will shrink. And as it shrinks, and we call it atrophy, is the medical term, but as it shrinks, it's replaced with collagen, which is scarring. So the patient who has good quality erections has a certain length. And when they get erectile dysfunction, for whatever reason, that smooth muscle gets replaced with collagen and the penis is shorter. So when they get a penile implant, for example, they always say, well, I used to be this long. Now I'm not that long. I'm an inch or 2 centimeters, whatever you want to say, shorter. And I tell them this preoperatively, that no question about it, you will not have your 18-year-old penis again. If I could make, and I always tell them this, and I'm very serious about this, if I can make penises longer, I tell them they get the operation second because they're going to be behind me. I'm going first. But we put the maximum size device in that patients can accommodate. And that gives us great flexibility to make certain that we have these patients sized to the maximum ability. Next slide, please. And there's devices that we have that can expand in length and girth, and that's important. And patients that don't have Peyronie's disease or patients that don't have scarring, then you have the ability to utilize a device that potentially can expand in length and maybe over time can stretch the penis back closer to their God-given erection length by the device itself. Next slide, please. And again, patient partner satisfaction is very great. And it's been well documented in all our urologic literature for a long time. And remember, this device has been around for 54 years. And it's a very effective way when non-surgical options to treat ED are not effective. Next slide. This just shows, again, the reiteration of what I said and published in our literature. On the bottom gold bar, you can see that those are the patients that had a penile implant. Their patient satisfaction is much higher than the use of oral pills and the injection therapy itself. Next slide. There's 2 approaches that you can utilize. One approach, go ahead to the next slide. It's called the infrapubic approach. You make a small incision right above the base of the penis. Through that incision, you're allowed the opportunity to place a reservoir. You can go through what we call the inguinal ring, which is where our spermatic cord goes up. Someone develops a hernia, that's where it would be, but that's the area we would go in. And or you can place it under direct vision underneath the rectus muscle, it's called, which is our abdominal wall muscle that comes down and attaches to our pubic bone. So that approach is one approach. You're able to place the reservoir, the pump's placed lateral to a testicle, and we're able to open the erection bodies and implant the maximum size device that the patient's penis will accommodate. Next slide. The disadvantages of that, the main one is you can potentially damage the nerve that creates the sensitivity, but the way surgeons are all trained now, both in their residency and or fellowships, and the implanting surgeons around the world know what this nerve looks like. So that's not a particular problem. So I want patients to understand that they're going to keep their sensitivity that they had going in as well. Next slide. And then the other approach that you can use is called a penoscrotal approach, which means it's an incision made between the junction of the penis and the scrotum. And through that approach, you can place the reservoir up through the inguinal ring or in through the lateral abdominal wall. You can put the cylinders in, and you can also place the pump that's in the midline of the scrotum, or you can move it to one side or the other if a patient has a preference. And that's another surgical approach, and that is also utilized. Each are utilized probably 50% around the world. Next slide, please. Again, the disadvantage, you can't place the reservoir under direct vision like you can from above, but that's not an issue in the experienced implanting surgeon. And again, as I mentioned, the surgeons now are very well trained, and our outcomes are very good through either surgical approach for any of the three devices that we talked about. Next slide, please. Are there complications? Yeah, there can be. And the reason I bring this slide up is only to summarize in my discussion with you now is the fact that even though there are potential complications, these have been minimized. You can get infection. Like I said, it's less than 1% now. It used to be double digit. And so that's a big thing with regards to making sure we do the very best we can to give the patient the best opportunity to get a great outcome from the implantation of a penile prosthesis. There's also a condition that Dr. Stricker mentioned about called Peyronie's disease. Peyronie's disease is very common, actually. It's actually much more common than we used to think. We used to think it used to be, in a single digit percentage in the lower side. But now it's actually around 10 to 11% of the patient population is affected by Peyronie's disease. So it shouldn't be called a disease, but it has been called that forever. But anyway, it's a condition that Philip explained is scarring in the covering of the erection body. So we have three bodies in the penis. This one, we urinate and ejaculate through. It's not involved with the erection. Then we have the two erection bodies here. There's a heavy cover around them, and I'm going to call my fingers the covering, the tunica, as Philip mentioned. The tunica gets inflamed. It creates inflammation. Inflammation heals by laying down scar tissue, which is collagen. So everything stretches during the erection except the scar. And then patients get varying degrees of curvature. So that condition can be treated. You can do what we call as a plication, where you will take tucks on the opposite side to straighten it. In the real severe cases, you will have to do a grafting procedure where we open up the scar and put in a collagen graft that gets absorbed. And I've been doing that for many, many years. And then, of course, you can use a penile implant in the patient that is impotent. So with that being said, I'm going to conclude my discussion to remain closely on time. And I'm going to turn it back to you, Kelly.
Thank you so much. That was a brilliant talk. And thanks for sticking to the time. You really made me chuckle there with your comment on if there was a penile lengthening procedure, it'd be first in line. I think that's a great line.
I'm signed up. I'm the first one. I'm the first one.
It's amazing. I don't know if you, sorry.
You being a urologist, you obviously know that. And I have to say this, in 35 years of practice, I've not had one patient come into my office and tell me his penis was too long. So anyway,
Yes. Well, I come from Africa, and on every traffic light pole, we have penile enlargements done by who knows who. It's very interesting. I don't know if you know Professor Wayne Hellstrom in Tulane in New Orleans. He always tells me that the amount of money that people, you know him, the amount of money people paid and fly across the United States, you know, to try and come and get some kind of enlarging surgery. But anyway, so we had some questions for you in the chat. Can a malleable implant cause any issues passing urine over time with it having been bent down like that most of the day?
Great question. Again, as I explained, there's those three bodies in the penis. I don't know if this portrays it there. That may be a little better. This is where the malleable device is, and this is where we urinate and ejaculate through. And just because it's bent, all three bodies, it does not interfere with urination. So if a patient has a malleable device or an inflatable device, there's no change in urination with regards to that. But that's a very good question. It doesn't interfere with the lumen of the urethra, which is where we pass our urine from the bladder to the outside.
That's great, a great explanation. I teach anatomy as well, and I normally use Play-Doh to demonstrate those cylinders for people, those medical students to understand. But that's a great the way you use your fingers there to explain the anatomy of the penis. We have another question. Someone who has had non-nerve sparing surgery or permanent nerve damage from diabetes, who is a candidate for prosthesis, what do you do to get the head of the penis a bit more rigid? And can PDE5 inhibitors help with that?
Yeah, that's a great question, because as I explained with my fingers, the three ways, the urethra, or the corpus spongiosum we call it, but the urethra, the channel where we pass our urine, the head of the penis is a continuation of that. And that has its own separate blood supply, and it's totally separate from the blood supply that goes into the erection bodies. When patients lose their erectile ability, they usually lose some of the ability to get glandular engorgement. PDE5s can help. That's the oral pills, the Viagra, the Cialis, the drugs that Philip mentioned. They can help engorge that. But many times, what patients have to understand is that the penile implant is not going to increase glandular engorgement. So I always tell my patients, after they get their prosthesis placed, they need to go ahead and have foreplay, any type of blood flow that can go into the head of the penis, into the urethra, which is separate from the erection bodies, but that goes also into the erection bodies. Then I tell them to inflate the device. If they have an inflatable, if they have a malleable, then that's the best opportunity to have as much girth expansion and glandular engorgement that you can get. But glandular engorgement does not come from just the placement of an implant. So PDE5s can be used. Sometimes I have patients that'll use a vacuum device to pull the blood into the glands and the rest of the shaft of the penis with their implant, and then they will resume or start sexual activity.
Another question, thank you for that. Another question here, if patients who have Peyronie's disease and then you put a prosthesis in, can they develop Peyronie's disease again? Or can it get worse?
That's a great question. When they get Peyronie's disease and it lays down the scar tissue that is not allowing the penis to expand and become straight, and you place an implant, after it's been straightened by the implantation of the penile prosthesis, or you have to graft over it, or you plicate before you put the implant in, meaning you straighten the penis and then it's going to have an implant. Once the implant is in, Peyronie's disease will not create curvature because the implant will override that curvature. So if you have Peyronie's disease and you get an implant, you will not have a bent penis.
Great, thank you. So there is another question about I'm going to incorporate it into our panel discussion. So I wanted to bring Professor Stricker back. Are you still there?
Yes, I am.
Oh, lovely. I had a question for you because you would understand the Australian healthcare system better. Are penile implants remunerated by Medicare, or does it have to? Is it only done privately?
No, penile prostheses in Australia is fully rebatable from Medicare and health funds. And it's interesting because on the converse, breast prostheses, if I'm not wrong, is not rebated.
That is interesting. Well, thanks for
Even
I think it's because of the history of how it all happened. The first treatment of erectile dysfunction, the physical problem of erectile dysfunction, which in the 80s was mainly due to vascular disease and diabetes, not so much prostate cancer surgery. It was a physical condition that affected reasonably young people, particularly insulin-dependent diabetics. And as it was the only treatment before injections, before tablets, it got up through Medicare to have an item number. And it wasn't plastic surgery, it was the condition of a failed penile mechanism. And so it's historical. If you tried to get it up now, my guess is you wouldn't.
Interesting. Dean, were you going to say something? Sorry, I didn't.
No, that's very interesting what Philip just said. And it's actually reversed for the US, where it was because of the fact that breast cancer reconstruction for breast implants was covered. Then they said, well, if you develop ED because of prostate cancer, let's say, why wouldn't that be covered as a potential complication of the therapy? And it's very interesting. And I like your choice of words, Phil. Get it up.
Most appropriate. We cannot have a webinar like this without mentioning.
I've always liked when I first met Philip, when he said, you know, once I'd had surgery, he said, you know, use it or lose it. And I think that that's very true. And that actually, I'm getting questions coming through on my phone. But one thing I'd like to come back to on the testosterone issue, and we've had a number of members of our support group that have had very low readings of testosterone, basically their health practitioner has not done anything about that. Phil, can you just explain a little bit further on? I can always remember that, you know, it was veer away from testosterone, you know, drink soy milk, whatever, you know what I mean? That kind of information. Has things changed from what you were just saying earlier?
Yeah, look, I think the fear of testosterone replacement to a physiological level is no longer justified. You know, that even a small dose of testosterone will speed up your cancer or bring a cancer on. That's no longer a fact. I mean, a muscle builder who decides to have supra physiological doses of testosterone is a totally different story. Yeah. Those people possibly are putting themselves at risk. But I think your question, Gary, comes from, I believe, people who might have been on androgen deprivation therapy.
Right.
And after quite a long time, maybe even 6, 9, 12 months afterwards, their testosterone doesn't recover. And they're on a period, either a short-term period of hormone therapy in association with radiation, or they're on intermittent pulses of hormone therapy. And it's become much more commonplace these days that some of the people who are on androgen deprivation therapy are given testosterone replacement to get to physiological levels if after a reasonable period of recovery, it hasn't recovered. And what's been published is that between 10 to 20% of people who are on androgen deprivation therapy never get their testosterone back. And those people will benefit from having testosterone to a physiological level.
Right.
That's great. I have, you mentioned radiation. I actually just wanted to ask, what are the treatment options for people that have had radiation, whether it be brachytherapy, external beam? Does medical treatment work? And then at Dean, can you put an implant in for someone who's had radiation?
Philip, go ahead. Now I'll follow.
Well, look, I think that the first question you asked, Kalli, was, what are the options, I presume, for prostate cancer in the failed radiotherapy patient? I think that's what your first question was. And
Yep.
then you went on to ask a separate question about impotence afterwards.
Yeah.
So if I can answer the first one, when radiation fails, and it fails in a local sense, in other words, the cancer comes back in the prostate, there are 3 ways of addressing it. One way is to say any local treatment's too dangerous and we're just going to put you on hormone therapy. That's one option. And the reason why any local treatment's too dangerous is because the surgical removal of the prostate in that context leads to a high side effect profile, a very high chance of incontinence, and a very high chance of impotence, and even the possibility of really serious complications. So that's that. Having said that, and you can't do radiotherapy twice. That's the other problem. You can't then go and do brachytherapy, although if the radiotherapy's been done more than 10 years ago, there are trials being done for high dose rate brachytherapy as a standalone boost in those people, but they're very immature and not standard of care. The other possibility is this is a really rife area for ablative therapies. And I've been doing some work with irreversible electroporation, and other people have done cryotherapy and HIFU in this exact setting. And we are just about to publish the results of 100 patients after previous radiotherapy, where we used irreversible electroporation to ablate that with an 80% 5-year biochemical disease-free survival with almost no incontinence. And that, in a highly select group of people, may be an option. And so,
can I interrupt, because we've got a mostly lay audience? Can you explain this procedure and what do you mean by ablation? Because not everyone may understand what that means.
Ablation means using some energy source to destroy the cancerous area. Most of these energy sources are heating or freezing, but the one that I'm keen on is where we pass electrical currents at very high current across the tissue just by putting little electrodes into the prostate as a day procedure and destroy the tissue using electricity. The company calls it nanoknife for sexy, uptake, but the real name for it is irreversible. In other words, you can't reverse it, electroporation, or the passage of electricity. Day procedure, very safe, and I'm probably one of the pioneers of that.
Wow. And you said that only in a select group of patients. Can you just tell us what that select group is so that our members know?
So when you introduce new technologies, the ethics committee will say, rule 1, do no harm. And so do no harm means let's have a small cancer in a person which isn't too extensive. And so we tend to say less than half of the prostates involved, PSA is pretty low, and the recurrent cancer's picked up early. So in that situation, after complete informed consent, often as part of a clinical trial, they will have that treatment.
And why can you explain? I know the answer, but can you explain why is sexual function preserved with this type of?
No, I didn't say sexual function was preserved. I said it had the least effect on sexual function.
Okay.
So the data that we're going to publish is in the post-radiation setting.
Yeah.
Some patients have already lost sexual function.
Right.
So in our series of 100, and don't forget, this is an incredibly highly select group of people. We had about 50 to 60% of people who were still potent after their radiation. That went down to 30% after the nanoknife treatment.
Right. Okay. And now Dean was going to explain about the implants. Can we do implants after radiation?
Yeah, absolutely. Obviously, the radiated patient can develop ED. So it affects the nerves, it affects the arteries, and any type of radiation, whether it's proton therapy, whether it's external beam radiation therapy, or it's brachytherapy or cryotherapy, which is not radiation, but those patients develop ED. And if they do, of course, we go through the spectrum. So that's an excellent question, Kelly, because it gives me the opportunity to sit and explain, what do we usually do for the patient who's been radiated. Of course, we always want to try the first line therapy, which is oral therapy. So we'll try the drugs. We'll try a daily dose of tadalafil, which is generic Cialis. After 5 days, you have a steady state of drug, and then that then doesn't make sexual activity have to be timed to the use of a medication an hour or 2 hours before, as we've seen. If that doesn't work, then what I do is I talk to my patients and I say, here's all the other lines of therapy. You can use a vacuum device, you can use injections, or you can do an implant. There's a drug out there that we used to place in the urethra called Muse, which is a prostadil, PGE1, but it's not effective in 99% of my patients, and it's very expensive in our country. But then I offer the patients the next 3 lines of therapy. So, Kalli, to answer your question, any patient who's been radiated, regardless what type of radiation has been administered, those patients are still very, very good candidates for an implant, and there's no increased complications from placing an implant into a patient who's been radiated.
Thank you so much. Yep, that does answer the question. I'm going to take it back a little bit more to the concept of prehabilitation and penile rehabilitation. And actually, one of the participants has got a question here. He's recently had nerve-sparing prostatectomy. Could you talk about the importance of maintaining erections during the recovery period until nerve regrowth occurs? And indeed, can I assume that it will occur? Then there's a question. I mean, I can pose one of these each at a time, but I'll give you all the questions at once. Are there any advantages in this period of doing injections versus the tablets, PDF5s? He's noticed that Cialis gives him backache. Is there another option? And how important is it to achieve full erections during this period? Or is a semi-hard state still okay, using less medication? And is a daily dose okay? So there's a million questions in there, but maybe we can bundle it into a little talk about penile rehabilitation.
Do you want me to go first, or do you want to go, Dean?
Oh, you go first, Philip, and then I'll follow.
So penile rehabilitation is controversial. I think if you look at the real hard data, probably it's pretty soft in terms of whether one thing does better than another. But I think what is true is that use it or lose it is really important. And it seems that being active sexually is the critical thing rather than exactly how you do it. Whether it's an injection, regular tablets, as you use tablets. And I can show you literature supporting each one of them above the other. But the only real trial that was ever showed that had level 1 evidence was a trial by Francesco Montorsi, where he compared people who didn't have injections, who did have injections. And that's been the only real prospective trial. And that didn't have many numbers in it. So you could argue about that even too. So my answer is there are a lot of different rehabilitation programs. The one I personally use is a regular dose of PDE5s, encourage them to use it, give them realistic expectations about sexual recovery. The first year is not a great recovery year. The second year is a great recovery year. And also get them to use a vacuum device, because I think there is some evidence for that avoiding penile shortening. The injections, whilst there's a great advantage in terms of using them for reliability of erections, there's a great disadvantage that it can cause Peyronie's disease or increase the chance of it. And so it's all, it's a discussion either way, and every person's an individual, but that's how I'd address it.
Do you think any of the PDE5 inhibitors cause less backache than, say, Cialis, or do they all cause backache?
Cialis is the worst.
Okay. All right. Dean was going to say something as well.
Yeah, no, and I agree with Philip. We of course came into the concept of a nerve-sparing prostatectomy, and you leave the nerves behind, and you think, well, they're potent going in, they ought to be potent coming out. Well, it's not always true, and so then of course we go into the whole spectrum of penile rehabilitation, and it of course is everyone tries everything to try to get their erections back. So we all place our patients on daily Cialis. We have our patients use a vacuum device daily for 5 to 10 minutes, without a trapping band, just to expand the spaces that fill up with the blood, and that type of situation. And as Philip explained, it's across the board, and it's so variable. But what you really want to do is engage the patient to understand that their possibility of maintaining their normal erections is involving their input. And so we put them on the drugs, we put them on a vacuum device. Patient says, well, the drugs don't work. Well, then I'll put them on injection therapy. And just to make sure we try to get them to get their return of the God-given erection, if you will. I can tell you this, in my experience now, and Philip, you may have a different opinion or the same, but if I see a patient who has his prostate removed or his prostate treated with radiation therapy, usually radiation therapy, when they get ED, it's a little more delayed than it is when the patient gets his prostate removed, even if it's a nerve-sparing, robotic prostatectomy, is the fact that if they don't see a big change between 6 months and 9 months, of course, at the beginning they don't, and then they get to 6 months, 3 months, 6 months, 9 months, and they don't see a big change occurring with the use of these things, then I intervene with more invasive therapy. I'll offer an implant earlier. The old days, we used to say, well, we'll wait 18, 24 months, that your erections will get better. They don't. And so I don't want those patients to suffer an additional year, without the ability to have normal sexual function.
So I wanted to ask, when would either of you refer a patient to a sex therapist?
Well, what we do is we have a team of people as part of our protocol before surgery. And that team is my clinical nurse, Jane Matthews, who's been with me for 30 years, counseled over 7,000 men, and she's better than any sex therapist ever. And so, the word sex therapist just means they've got a degree after their name. What a sex therapist is somebody who walks the person through a very complex sexual rehabilitation process. And so every single person gets Jane, and occasional people who are really suffering get a clinical psychologist on top of it, or Michael Lowy, who's our sexual health physician, in terms of the more physical side of things. We offer it, Michael Lowy, to everybody, or Chris McMahon, who's now retired. But very few people, apart from very young people, take that up initially. They more take it up afterwards if there's an issue.
Dean, did you want to add something from your practice?
I can say this, in our particular situation, it's not generally well accepted until we can get our patient to understand that, wow, you truly could benefit potentially from additional, psychological therapy. And again, it's not that well accepted where I practice.
Well, in our next webinar, we'll be hearing from a sex therapist. It'll be interesting to hear their perspective.
Can I just ask a question of both of you? once you've had your prostate removed, if after between 6 and 12 months, you're not getting, even with practice makes perfect, you're not getting erectile response and it's not happening, what would you say? What's the expected time now? I know it depends on, how successful the whole removal of the prostate is and what you've been able to save from a nerve perspective. But when should someone worry? Because I know from our support group, we've got a mixture of young men that have had their prostate removed, leading right up to people that are in their 80s, and all of them would desperately like to continue to have some form of sexual function in life. And so, what can people expect now, do you think? Or what's the period of time when they should start to engage with people like yourself to be able to think of, other therapies?
Gary, you bring up a very, very good question. And again, it's funny how the pendulum swings. And I've done many prostate removals myself, both open and robotic. And the bottom line is we used to say, well, if you did nerve sparing, you should wait 18 to 24 months. I've not seen the patient at 6 months get better to the point where he had good erectile function at 18 months. So I tend to get to the point where, as I mentioned earlier, if they get to 6 to 9 months and they're not really seeing any appreciable change and they're not getting any appreciable response to the therapy that they're on, which of course is the oral drugs, the vacuum therapy, and some of them on injection therapy. If they don't want to do injection therapy, I'll offer those patients a penile implant as early as 9 months. I don't wait as long as I used to because we thought it would get better. But I didn't see that in my clinical experience. And I don't want these patients to go another year without even have the ability to have, sexual function.
So I've got a slightly different perspective on that. We did a quality of life study of my patients and also the units at St. Vincent's. And we found that the majority of recovery occurred in the second post-operative year, not the first. But I accept from Dean that if you've got no function at the beginning, as opposed to maybe tumescence and early rigidity in the first 6 to 9 months, then I accept that those people with no function are never going to get over the line. So I separate them into people, towards a year, and when they come back for their year follow-up, they're either nil, in other words, that person may as well be treated now, and I'd agree with Dean, or that they call it 50%, not quite sufficient for penetration. I'd give them another year, because I think those people sometimes do get over the line, but they'll only get to 75%. They won't get to 100%. And even occasionally, those people might end up having a prosthesis. But I think if they're getting to that point, some of them are pretty happy with a combination of a constriction basal ring and a tablet at a year. And then, of course, there's the other group, which we don't talk about, which is the 40% of people who do brilliantly from the word go. And, there's no point talking about them because they're happy.
Yeah.
Yeah, those are the ones that don't come back to tell me that they're not getting good erections.
Yeah. Sorry, once again, because we have varied groups of health literacy here, just what is nerve sparing exactly for our listeners? What do you mean, and how do you preserve those nerves?
Phil, go ahead.
Yes, so there's a bundle of tissue on either side of the back of the prostate, about 1 centimeter in diameter, which incorporates thousands of tiny microscopic nerves, arteries, veins, and scaffolding, and it works together as a whole syncytium to make everything work. And they connect the brain to the penis to allow the chemical to be released at the penis so that the blood vessels open. And the more damage you do to those bundles of tissue, the more chance you have of erection problems. And so cutting them out is one thing, but even bruising, heating, and stretching them is another, which sometimes has irreversible damage depending on the person. And that's what Dean and I are talking about. We're talking about not the people where you cut them out, but you're talking about the people where the surgeon, is patting himself on the back saying, gee, they look good, those nerves, yet the patient isn't happy and the patient doesn't have a good erection. So obviously there's been some damage to these very fine and incredibly sensitive nerves. Now, when you preserve nerves or you preserve some of that 1 centimeter tissue on both sides, you go closer to the prostate. So you increase your risk of leaving cancer behind because you're going closer to the prostate. So the balance for the surgeon is to go wide enough to clear the cancer, but close enough to preserve the nerves. And that's what this is all about. In the past, we used to think it was black and white. You either took the nerve or you didn't. But now we realize there are shades of gray where you can take a little bit of the nerve, but still get a clear margin and still increase the chance of potency. So, and I think Vip Patel should be congratulated for most of that work because he did a lot of that fine shades of gray.
Yeah.
Yeah. Is there any imaging or 3D modeling you could do which could show you exactly where those nerves were to avoid them?
No, not that I know of.
Well, we know where the nerves are. It's more to do how sensitive they are to how we operate. And it's neurosurgery of demyelinated nerves, which don't take much to switch them off.
Yeah.
I do a lot of Peroni surgery for the real bent penis, very bent. And those patients, I take the neurovascular bundle off the top of the penis, meaning the nerves and the arteries that live on top, and you take them away from the erection bodies and you open up the curvature, the scarring, and open it, and then you graft into it. Those patients, they certainly can have changes in those nerves, even though the fact that you isolate them, you elevate them, and they can have decreased sensation that can last up to 6 months. So you touch a nerve and it can go to sleep for a long time, like Philip was saying.
Now, I know we touched on penile rehabilitation. There's also a concept of prehabilitation where you start taking those PDE5 inhibitors before surgery. I know Phil had said there's no evidence even for the other, or minimal evidence for the other, but is there a role for prehabilitation or not? And what is it?
I have a simple answer for that, no.
My simple answer is use it as many times as you can before your therapy, because you don't have any idea what it's going to be like afterwards.
Thank you. Dean, back to you. Regarding implants, this is my question. I know with artificial urinary sphincters, there's been talk about having a Bluetooth or Wi-Fi sort of connected to your phone and the device. You don't have to worry about the pump, which comes with its own issues and it's easier to use. Is that something they'll consider for penile implants as well?
Oh, absolutely. I have been involved. There's 4 of us in the US that have looked at the original cadaver work back in June of 2021. And basically what it's looking at is eliminating the pump. And the pump of the implant sometimes becomes an issue. The patient develops problems with dexterity and they can't utilize it and pump it up correctly. Sometimes there's mechanical, the pump doesn't totally lock in or lock out. And so the idea is to eliminate the pump. So basically you'll have 2 inflatable cylinders. You'll still have this is the inflatable device, of course, and you'll have a reservoir. And then there's a canister or a can, which will have a motor to transfer the fluid from the reservoir to the implant, much greater than a patient or I could manually. When we squeeze a pump, we only get 14 pounds per square inch. But anyway, I don't want to get too technical, but this goes even another 25% greater. So the patient has the ability to potentially graduate what type of quality erection he wants. And then it's rechargeable, but it's all programmable by Bluetooth technology. And that's coming. And it'll probably take another 4 or 5 years before but we're probably a year away from starting clinical trials, at that time. But if you get a penile implant in 2027, it'll be Bluetooth technology.
An app,
And if you have,
Brilliant.
an app.
Gary?
yeah, and if you have an implant put in today with a pump, you can still get Bluetooth technology in 2027. Whenever it comes about, just remove the pump, put the pump canister, we call it. So it's the pump and the rechargeable process of it, the computer component of it. But it's coming. And it's also coming for the artificial urinary sphincter. Actually, the artificial urinary sphincter, which I'm involved with both, is well ahead of where it is for the penile implant. Yeah. So eventually you can run it from your watch or your cell phone. So don't leave your watch or cell phone at home.
Thank you for that. There was another question from someone listening. Can you have a penile implant if you've had a pelvic sling?
Absolutely. Yes. It makes it a little more technically challenging, if you will, for the implanting surgeon, but absolutely. So if you have a sling put in, which is to elevate the urethra up into the pelvic inlet so that when they cough, sneeze, and laugh and the pressure comes down, it hits the sling, then if it doesn't become effective for those patients and they still have incontinence, then they definitely still are candidates for an artificial urinary sphincter. No question.
Thank you for that. There's two other questions. This one often comes up about steroids and gym. Can men cause erectile dysfunction or sexual dysfunction by the use of steroids for gym purposes?
I don't know if I know the answer of that. I've certainly seen people who have so much testosterone that they get testicular atrophy.
Yeah.
And it suppresses their testicles and they shrink down. And I would imagine if they then get off the testosterone, it's quite possible that they're hypogonadal and that could cause it. So I suppose the answer is yes. I think anybody who has supraphysiological doses of testosterone is putting themselves at risk.
Yeah, that makes sense. And the last question we had was, can you talk about oxytocin for anorgasmia? Something either of you have had experience with? It's quite medical.
No. The only reason I cringed is because one of the most difficult situations that I absolutely have encountered in my career in urology has been the management of anorgasmia. It's very, very difficult. We've tried all the medications, and usually they're not effective. And it's a very tough situation. And that can happen too, even after patients have penile implants, and they still have the same condition. They have it going in, they have it coming out. You think with a full erection, better stimulation of the penis, that they may overcome their anorgasmia. That's a very, very difficult situation. I can tell you, I tell my patients, and they come in and they ask me, well, is there anything new? And I have a list of probably 200 guys on it that I said, as soon as I find something that we think is going to work, I'll call all of you up, I promise you. But I've not had any good results with any medical therapy for anorgasmia. Phil?
Yeah, look, I unfortunately have to echo your sentiment. I think, we're taught traditionally that anorgasmia is a psychological issue. But, I've heard of lots of psychological issues that turn out to be physical, and we just didn't understand them. But if it is psychological and they go to a clinical psychologist of top repute, none of them improve. So I don't know what the answer is to that.
I wish I had an answer.
Yeah. But so they would have anorgasmia, they'd still have the sensation of ejaculation though, because that's applied.
No. That they can't get to an orgasm. They cannot get to an orgasm, and ejaculation occurs with an orgasm. And so it's not lack of ejaculation, it's lack of actually the pleasurable sensation that is associated with rhythmic contractions of your pelvic floor and an epileptic-like phenomena in your brain.
Yeah.
And hence the reason when he said we thought it was all psychogenic, we always say, well, we were always taught orgasm is mental, ejaculation is physiologic, but the two kind of have to connect. And if they're not connected, either one happens.
Yep, that is very interesting. Gary, is there anything you wanted to?
Yeah, I've got. We previously had a speaker when we had a webinar on incontinence, and he made the statement: no one today should walk around being wet. I put to both of you, given your superb presentations today, and being a survivor, I agree. I had none of the issues with incontinence, and I got my erections back very quickly. So 100% satisfied. But I think one of the things I have noticed with all of our members as they come through our support group and other men and other groups of men that I've spoken to that have had prostate cancer, would you say that today a similar statement is in relation to being able to get an erection and being able to solve the problem of being able to engage in pleasurable sex again, that you can have a sex life and function as near to normal?
I think you said two comments there. Your very first one was you can have a sex life, and then your second comment was function near to normal.
Yeah.
I think, as with all these things, it's all about matching expectations with reality. And I think that your first thing is have a sex life. I 100% agree.
Yeah.
You can have a sex life. And a lot of my patients, people have been married for years and years, have a thing called outer course very happily and continue to have mutually satisfactory orgasms. Is that a satisfactory sex life? Yes, for those two people. Is that as it was before? No, it isn't.
Yes.
So I think that the statement that would be fair is that you should be able to get every patient to a level of to some form of sexual activity if they want it, because some of them don't want it. But if they want it, in all cases, you should be able to at least assist them to get to some level of sexual satisfaction. Is it the same as it was? Probably not.
It is. I mean, I look at it from the perspective and the way I explained it is about reinvention after you've gone through, a journey of prostate cancer, and you can find satisfaction. You can find just as enjoyable. It is about, but the problem is we're not all taught how to reinvent ourselves, and some people don't know how to do that, and that's part of all of the support that you're talking about with the likes of Jane and everybody else to be able to explore what's possible.
Dean?
Oh, I couldn't agree more. What is normal of what they are capable of accomplishing and or happily satisfied with that particular aspect of their sexual function. I always tell patients, you can always be happy with sexual function as long as you understand how you have to get there. And if it's outer course or intercourse, we can always make a patient potent. There's no question about that. And that's one thing I will say. And I heard you mention incontinence. I do a lot of artificial urinary sphincters and male slings in patients that have post prostatectomy therapy, or surgery and or therapy for their prostate cancer. I can't look at them and say you're going to be 100% dry, but I can look at a potent patient, an impotent patient, and say I can make you potent 100% of the time. And it's just how you want to arrive there to get there. But again, I think it's important to let them know. And I think one of the most important things, and I know Philip, you have this in your organization, and we do as well in our processes. It's educating the patient before their prostate cancer therapy, if you will, what they can expect and what may be needed to allow them to resume normal function. So we look at them. We have three goals. One, we want to cure your cancer. Two, we want to make you dry. Three, we want to make you potent. And those are very important issues. And the latter one, we can do 100% of the time. The second one, maybe 90% of the time. And the first one, hopefully 100%, but not always. But depends on every clinical situation there.
Thank you.
Well, I think we're nearing the end of our session, so I just wanted to get some final thoughts or any closing remarks. Phil, do you want to say anything before we end?
I'd just like to congratulate you guys for putting the time in to make this all happen, because we set up the first prostate cancer support group in Australia at St. Vincent's in 1992. And a guy called Max Gardner was the person who really was the driving force behind that. He, and with a little bit of help from people like myself, set up a thing called the Prostate Cancer Foundation of Australia. And this is now 30 years down the track, helping people around the country and even wider to understand what their options are. So it heartens me enormously to know that that little support group with 4 guys at Vinnie's and with Max Gardner has led to incredibly data-rich and empathetic conversations that we're having with people who've spent their whole lives dealing with this. And I just want to congratulate you for doing it.
And I think we should congratulate you too for starting this off. And you should be very proud of what you've achieved.
Yeah, absolutely. We've got Anne Savage, who's the CEO of Prostate Cancer Foundation now, and she's one of our attendees today. So welcome to you, Anne. I'd like to say that today's just been an amazing presentation. Dean, thank you so much for your time. And Philip, again, thanks so much. You've been so supportive of everything that we've tried to do and been a keynote speaker at so many things, and it's absolutely fantastic.
Gary, we need to give Dean a final thought as well.
Yeah, I will. I was just going to go on to that, but I just wanted to say that I think that webinars such as this and getting the information directly from people like yourself is just been brilliant.
Thank you. Dean, do you want to give us a final thought? Or?
Well, obviously, I was very intrigued by the concept when it was presented to me about what this particular program would be about. So here I am at midnight and Friday night in Nashville, Tennessee, and I'm enjoying this. So first of all, I want to congratulate all of you on the educational aspect of making patients aware of what they're dealing with, what can be done, and how they can get through this particular issue. Gary, Kalli, and of course, anytime I have the opportunity to be around Philip and we share our experiences and our trials and tribulations and failures, it makes us better. And this is a perfect example of starting here and ending up here. So congratulations to all 3 of you, and honored to be involved. And I hope we can help people further. And with that being said, I'm honored.
Thank you very much. And again, for staying up to midnight. I don't know if you would be line dancing in Nashville, Tennessee on a Friday night. I'm not sure what happens. But
that occurred before I came. I'm kidding. Yeah, I'm kidding.
Well, thanks for sacrificing the time from that to join us.
No, it's not sacrifice. It's an honor. It's a privilege, believe me. Yeah.
Well, thank you all, and we just want to let everyone listening know that our next webinar will be all about living well with a prostate cancer diagnosis. So we will have a dietitian, a exercise physiologist, and then, as I said, a sexual therapist, psychologist, to talk about some of the wellness aspects and sexual intimacy as well, which will nicely complement today's session. So yeah, please stay in touch. You have our details. Email us anytime. You're welcome always to join our support group, which is the first Saturday of every month. And we have a hybrid session now using Zoom. So either you can come face to face to the group in Sydney or join the session live via Zoom. So thanks to Gary again for putting this all together. We really do appreciate your efforts. There's a lot that goes on behind the scenes. And thanks also to Nicholas, who's doing the IT for us today as well.
Just before I say goodbye, thanks to Boston Scientific and to PCFA for allowing this to all happen, which is absolutely critical. And also to everybody, including all the support group leaders, whether it be in Australia, New Zealand or parts of Asia. This will be going on to YouTube and will be available sometime next week. The previous webinars that we have are on that YouTube channel as well. Thank you very much, everybody. Philip, Dean, thank you.
Thank you, Gary.
Yep.
Bye, everyone.
Cheers.